This episode of the Imprint Weekly podcast is sponsored by Kemp Center. 4 days, 60 hours, 250 sessions, and 500 presenters, with an anticipated 3,000 change agents from around the world on a mission to change child welfare as we know it. Join us October 3rd through 6th, 2022, at the Kemp Center's International Virtual Call to Action Conference to Change Child Welfare. For more information, visit kempconference.org. That's KEMPE conference.org.
Hello and welcome to the Imprint Weekly Podcast. I'm John Kelly, Senior Editor of the Imprint, a daily news site covering child welfare and youth justice around the country. You can read all of our coverage at imprintnews.org or check us out on Facebook or Twitter at the Imprint News. You can also sign up on our homepage for our free weekly and monthly newsletters. And for professionals in child welfare and youth justice, subscribe to our Youth Services Insider section for a closer look at news on business, policy, and practice. On this week's podcast, Jenny Harper of Nurse Family Partnership joins us to discuss the looming fiscal cliff facing America's largest fund for home visiting programs, many of which have shown great promise in supporting young mothers and child well-being. First, let's get to a few headlines, and we're going to start with two that really speak to the power of good journalism when it comes to youth and family services. In 2014, an investigative series by the Bay Area News Group exposed the excessive use of powerful psychiatric drugs on California kids in foster care, and that expose spurred legislative and policy changes aimed at curbing the use of such medications. Now, a new study suggests that those actions likely had a significant effect, especially when it comes to antipsychotic drugs, which carry the greatest risk of dangerous side effects of any of the so-called psychotropic meds. The number of antipsychotic prescriptions filled for youth in California foster care dropped 58% statewide in a span of a decade. I'll post the Imprint's coverage of this from last week in our show notes, and we're going to have our executive editor at the Imprint, Karen Desau, who actually wrote Drugging Our Kids back in 2014, on the podcast pretty soon to go a little deeper into that original series. I think this comment in our recent piece, though, really sums things up nicely on the subject. This is from Jennifer Havens, who is the chair of the Department of Child and Adolescent Psychiatry at NYU's Grossman School of Medicine, who reviewed the study for us. And here's one comment she made to us. The treatment for post-traumatic stress disorder related stuff and all trauma-related challenges is psychotherapy. That's the evidence-based treatment for these kids. But we also use antipsychotics quite commonly for kids who are just angry, which is despicable. So what Havens is talking about there is at the heart of this issue with antipsychotics in particular, and what Drugging Our Kids surfaced as a series, which is that there's pretty strong evidence their value to child welfare agencies is often behavioral control more than treatment of underlying causes of behavior. I did a much less involved investigation of this issue back in 2010 about the use of antipsychotics in juvenile justice settings and found a similar phenomenon. First, that most state systems couldn't even tell you who was on them and for what inside juvenile facilities. But those who could reported a lot of it was connected to pretty basic mood disorders or even with no diagnosis, as opposed to bipolar disorder or schizophrenia, which is generally what antipsychotics are prescribed for in adults. There's even less evidence of their efficacy in anything with youth. When I was doing that report back in 2010 on the juvenile side, child psychologist Robert Foltz had just written about how this use of powerful drugs to chemically restrain kids made it harder to actually help them. In 2008, he argued in the journal Reclaiming Children and Youth that atypical antipsychotics are thought to succeed because they limit the flow of dopamine, but the drugs also likely have the added effect of reducing two other brain chemicals, and that's oxytocin and vasopressin. Both of those, he said in this 2008 article, play a critical part in what he called modulation of stress and social relatedness. Because the flow of oxytocin and vasopressin is stemmed, he wrote, an atypical antipsychotic, quote, proves to create a significant disadvantage when attempting to establish social bonds or a trust-building experience, end quote. There was a time during the Obama administration when it felt like, at least in the child welfare world, there was going to be some national effort to rein in the use of psychotropic meds on foster youth. The administration shopped around in its, proposed budgets a $500 million collaboration between two different agencies at the Department of Health and Human Services that would be aimed at helping states first just regulate and review prescriptions better, and then develop alternative responses to behavioral health needs for foster youth. Leaders on the Senate Finance Committee at the time also spoke out about, quote unquote, going on offense against mind-bending drugs for foster youth. I remember Senator Tom Harper, I believe, made that reference to mind-bending drugs. But really nothing came of that. Some states have had success in limiting antipsychotics, as California's numbers indicate. Similar results in Florida after the suicide of a 7-year-old in foster care named Gabriel Myers, who was on a whole slew of different drugs, including, I believe, 2 antipsychotics. That situation and that tragedy really kicked everybody into gear in Florida and led to some actions that have led to far better regulation of antipsychotics and just psychotropic meds in general in the state. A more recent action spurred by media coverage just transpired in Philadelphia, where the city council has passed what some advocates believe is the best legislation anywhere aimed at protecting the social security benefits of youth in foster care. Now, we've talked a few times about this issue on the podcast. In a nutshell, though, youth in foster care who have had a parent pass away or who are seriously disabled to the point where work would be a challenge can be eligible for supplemental security income. And what a whole bunch of recent reporting has brought to people's attention is that child welfare agencies are frequently becoming the recipient of those funds on behalf of the children in their care, and they are often using them to simply offset the cost of foster care, which is a no-no. They can be the recipient, but the money is either supposed to be saved for the youth or used to go kind of above and beyond what would normally be offered to them in the system. Now, the Philadelphia City Council's bill, which was passed last week, put some very clear guardrails in place to ensure that SSI benefits, as they're called, are being handled correctly. First, the bill requires that youth are screened for eligibility, helped with applying for the benefits, and then that efforts are made by the system to establish a recipient of the funds that is either in the child's family or connected to them in some way. Only in the event that there is not a willing payee to manage the money on behalf of the child would the child welfare agency then step in and do it themselves. And when the agency does become the payee, which I think would happen quite often, in cooperation with the child and the child's attorney or their guardian ad litem, the agency must use the benefits for, and here's the direct verbiage from the bill, must be used for services or needs not otherwise provided by the department or covered by health insurance, for example, disability aids, a car, or tools of the trade for employed youth, or conserving the benefits for the child's reasonably foreseeable future needs. So either, if the system becomes a payee, they need to be using it for stuff they wouldn't otherwise pay for, or they need to be saving it for the child's future. Now, Helen Jim was the councilwoman who introduced this measure, and she credited reporter Steve Volk with helping to spark this legislation. She said in a tweet that Volk's local investigative reporting covering Mr. Vaughn Jackson's attempts to recover SSI funds moved us to action. We'll link to Volk's article in the show notes for anybody who wants to read his work. All right, the last headline I wanted to discuss this week comes from some research done by Child Trends, which really does some of the best analytical work on child welfare spending and outcomes in the country, about what has happened in terms of child poverty in America over the past 30 or so years. And this was done in partnership somewhat with the New York Times, who reported on the findings. So I'm going to link folks to both the research by Child Trends and the story by the New York Times. So I'm just going to run down a little bit of the findings and then kind of speculate a bit on how I see it connecting into the broader world of child welfare. So the big bottom line here from this research is that child poverty has pretty steadily trended ever downwards since 1993, when nearly 3 in 10 kids in America lived in poverty. In 2019, by Child Trends research, 11.4% of children lived in poverty. In that same period, the percent of children living in deep poverty, which means under half of the poverty line, got chopped down from 7.3% to 3.2%, so basically cut in half. But while it's not reflected in this research, these indicators went down even further during the pandemic as the government turned on the spigot for a ton of spending aimed at keeping people employed, supporting those who are unemployed, and buffering households with kids with an enhanced child tax credit. So in the decades leading up to all of this, child poverty rates had been very responsive to economic recessions. If you look at the chart that Child Trends put together, which begins in 1967, there were 4 recessionary periods between then and 1993, and each time child poverty spiked. In the 2 clear recessions that have happened since 1993, child poverty was pretty much level and even declined towards the end of the Great Recession in 2009. So Child Trends team sought to tease out, to the extent possible, what caused this decline in child poverty. And their whole presentation is really fascinating. You should read it. I will link to it again. But I'll highlight some of the biggest takeaways here. The biggest is that the social safety net, things like earned income, tax credits, child tax credits, food stamps, WIC, are keeping far more children out of poverty now than in the early 1990s. The safety net cut child poverty by 9% in 1993, according to this analysis. By 2019, it was cutting child poverty by 44%. And that is true despite the fact that the most well-known safety net program from the 90s, Aid to Dependent Families and Children, commonly referred to as welfare payments, was ended by a bipartisan rewrite of welfare that turned this into the Temporary Assistance for Needy Families program, or TANF. Now, TANF brought in work requirements, but also many states have just moved away from using TANF for welfare payments at all, and instead use big chunks of what they get from the federal government for TANF to pay for targeted group support or even child welfare costs. So federal spending on welfare has dropped by almost 40%, and the number of children in poverty directly affected by these payments is down more than 80%, according to this Child Trends analysis. And the impact of the safety net has been much greater. Workforce participation also contributed. Child Trends priced this combination: lower unemployment rates, higher workforce participation by single moms, and rising minimum wages at a cumulative 33% in terms of explaining the decline in child poverty. And then the last one I wanted to point out is teen birth rates, which interestingly, the decline in this rate had almost no impact on child poverty, but it had a huge impact on the decline in deep child poverty. Child Trends says it's associated with 52% of the total decline in child deep poverty across this era between 1993 and 2019. Now, obviously, some of that is attributable to better decision-making by youth, better comprehensive sex education, but access to birth control and to abortions also played a role in driving down the teen birth rate. And so I think this identifies a clear point where the Dobbs decision recently permitting states to outright ban abortion could lead to an increase in child poverty in at least some states. Since the country could basically be turned into a control experiment on the consequences of abortion bans, we might quickly see what the change in a teen birth rate would do in states that are likely to ban abortion. So all of this analysis is interesting when you juxtapose it against the experience of child welfare during this time frame, in particular of foster care. Because looking at 3 key indicators of child welfare during this span of time between 93 and 2019, reports of abuse and neglect, confirmed cases of it, and foster care, they all kind of go in a different direction. So let's start with reports of abuse and neglect. There's no other way to describe it than that referrals or reports for maltreatment exploded in this time frame from an estimated 2 million in 1993 up to 4.4 million in 2019. All the statistics I'm about to kind of unload on you here are federal statistics, either from the AFCARS reports or from child maltreatment. And that was a pretty airtight climb upward with the reports. I think there was only 1 year in between 1993 and 2019 in which the estimated reports went down, and it was really only by a little bit. Now, part of that was definitely that in plenty of states, reporting requirements were enhanced during this time. More people became mandated reporters, which meant, of course, that more people had pressure to report with consequences for not doing so. So meanwhile, as reporting of maltreatment was more than doubling, the number of confirmed victims of abuse and neglect was pretty consistently dropping. The number of victims was over 1 million in 1993. It remained above 800,000 through the mid-2000s, then into the 700,000 range, then steadily into the 600,000 range after 2015. By 2019, it was down to 656,000 confirmed victims of abuse or neglect. So this is the metric of the three that seems to follow the child poverty path. As child poverty dropped, so did the number of confirmed victims of maltreatment. So way more reporting, way less victims as child poverty is steadily moving down. How about foster care? Well, based on the federal data, there is no way you could look at its use and say it was very related to poverty. 230,000 kids entered foster care in 1993, and there were a total of 445,000 kids in the system for that year's point-in-time count. Fast forward 26 years later to 2019, at the end of this child trends assessment, with child poverty decimated, 252,000 kids entered, and there were 427,000 kids in the system for that point-in-time count. Now, looking at entries into foster care, what seems to have the clearest impact is the rise in the use of different drugs. Crack in the 1980s into the early 90s, methamphetamines in the early to mid-2000s, and then opioids and heroin around 2012, 2013. There are notable increases in entries during each of those periods. The meth era rise is kind of the most visible, honestly, because it occurs while the actual foster care totals are steadily dropping in the wake of the Adoption and Safe Families Act. It was very controversial, but did contribute to a surge in exits from foster care that more than offset the rise in entries. So as the percent of children living in poverty dropped from 28% to 11%, reports of maltreatment went through the roof, documented victims of maltreatment plummeted, and the number of kids entering and living in foster care was pretty level at the ends, with a couple of peaks and valleys that correlate to spikes in certain popularity of drug use. One view of all of that would be to say that it runs against the notion that family separation, especially by foster care, is artificially high as a result of the confusion of poverty with neglect. That is a phrase you hear very often in discussions about reforming or even abolishing child welfare, very frequently followed by everybody nodding in agreement. But if the confusion of poverty with neglect leads to foster care, and there's so much less poverty to possibly confuse with neglect, why isn't there less foster care? There's another way to look at it. There's at least one other way to look at it. I'm sure there's others that I'm not thinking of. There's way less child poverty than there was a quarter century ago. And as child poverty becomes more rare, as there's less of it to possibly see, the poverty that is seen by mandated reporters, by investigators, by judges, is more likely to be confused with neglect or seen as a failure of a parent. However you view it, it does seem clear from history here that reducing poverty alone through concrete supports or better work opportunities or higher minimum wage is not likely to alter the use of foster care in the current constructs of child welfare. What does seem to alter its use is surges in drug use. Some of that is likely the confusion of drug use with neglect, that's for sure, but it also includes parents that do need help to get to a safe situation for their kids, and to rely less on foster care in those situations. It's going to require good programs to help them, more investment in those programs, and support for kinship caregivers and family friends to back them up in the short term. Anyway, this is admittedly speculative. I do hope Child Trends is going to kind of cross-analyze here, because they really are in a unique position expertise-wise to do that, to look at what they've found here with child poverty and kind of correlate it and explore its connections with child welfare operations. But if anybody listening to this podcast has some thoughts, hit us up at tips@imprintnews.org. All right, when we come back, our conversation with Jenny Harper of Nurse Family Partnership. If you are a caregiver, current or former foster youth, or work in a child welfare system, your voice matters, and it only takes a few minutes to help improve foster care. Help tell it to Congress in 2022 by participating in iFoster's Voice of the Community Survey. Take 5 minutes to complete the Voice of the Community Survey and be entered to win one of 10 $500 Visa gift cards. Just go to voiceoffostercare.org and click on the Take Year 2 Survey tab to take this year's survey. In 2021, over 2,400 people shared their opinions and experiences in the largest survey ever taken on the state of our foster care system. And it's having an impact. The report has been covered in the news, has been read by hundreds of elected officials, and it's shaping child welfare budgets and policies to focus on what the community wants. We even featured the results of the survey last year right here on the Imprint Weekly podcast. So take 5 minutes to improve foster care, complete the survey, and you might win a $500 Visa gift card just in time for some holiday shopping. Once again, to take this year's survey, go to voiceoffostercare.org and click on the Take Year 2 Survey tab to take this year's survey. The Maternal, Infant, and Early Childhood Home Visiting Program, which is a federal program that invests $400 million every year into helping to prepare new and expecting parents, is set to expire at the end of this month. Joining us to discuss where things stand in the push to get this program reauthorized is Jenny Harper, who is the Director of Federal Government Affairs at the Nurse Family Partnership. Jenny, thanks for joining us on the Imprint Weekly podcast.
Thanks for having me here today.
Absolutely. So before we get going on that, standing rules on our podcast, you gotta give me one of your favorites: book, TV show, movie, musical group, or sports team. Don't have to give me all those. Give me one or more. What do you got, Jenny?
I'll give you a sports team, Washington Nationals. I live right across the street from the baseball stadium, so even when the team is not having their best year, I'm still highly invested.
Let's start, for people who might not be up on this program, with kind of explaining the basics. So I introduced a very lengthy name: Maternal, Infant, and Early Childhood Home Visiting. Most people just refer to that, once they are familiar with it, as MIECHV, which is kind of a weird pronunciation of those letters. And it became a program as part of the Affordable Care Act. It's a mandatory spending line that sends funds to states for home visiting programs. So can you explain to the listeners what those are generally, and maybe go a little deeper on, Nurse Family Partnerships model by way of further example? But I guess let's start with just, what is a home visiting model do?
Great question. So a home visiting model, there's a lot of them. There's about 19 that are currently eligible for MIECHV funding right now. And so they might have a different area of emphasis, whether that's on more health outcomes or more educational outcomes. But essentially what they're all doing is they are providing a dedicated trained professional to a family, sometimes starting prenatally, sometimes starting after the child is born, but generally in those very early years, and providing that dedicated, trusted support to them to help partner with that parent and provide them resources, knowledge, education, information, referrals to what they need in order to successfully parent that child and to achieve great outcomes for that family.
So take people through like the NFP model, right? Like just, a hypothetical client that is referred to NFP or finds you guys. What are they going to get out of the experience of having a Nurse Family Partnership home visitor?
Yeah, so Nurse Family Partnership works with first-time low-income moms, and we begin that relationship prior to 28 weeks of pregnancy, and then continue to work with that family until the child's second birthday. And so those home visits with the mom in pregnancy will be, very focused on healthy pregnancy, nutrition, maybe smoking cessation, other things the mom might need, starting to talk about what it's going to be like when the baby comes, answering issues that they might have, concerns, whether that's around preeclampsia, whether it's around doing intimate partner violence screenings, really trying to assess what that mom or that family's needs are and helping to holistically address those. And so then as the baby comes into the picture, looking at safe sleep environments, general safety of that home environment. Also, making sure that baby's meeting the milestones, singing to the baby, reading to the baby, all of those early bonding, screening that mom for maternal depression, and then, really continuing to work with that mom as the child ages, again, up until the baby turns 2.
Right. So all the way through 2 years old is when you guys will work. And all these different models have different ranges of time. Some, I think, catch at birth, right? It varies kind of, but it's all early.
Yeah, and actually, Nurse Family Partnership merged last year with another evidence-based home visiting model, Child First. So Child First works with families as early as prenatally, but up through, the child's fifth, turning five, and they pair a master's level mental health clinician as well as a care coordinator with that family, really, again, addressing that family's holistic needs, providing parent-child psychotherapy to the family as the intervention. So it's a much more mental and behavioral focus, but it's, also a home visiting model. So again, coming to that family, at their home or at a place of their choosing, really meeting that family where they're at.
Right. So to bring these two things together, like Nurse Family Partnership, some of these other, frankly, probably all of the home visiting models existed before there was MIECHV, right?
Yeah.
MIECHV was this part of the Affordable Care Act, which obviously was quite politically divisive in some ways, not so with home visiting. I think there was pretty much bipartisan support to get that into the mix and get it funded. So just in the, to use Nurse Family Partnership again as kind of an example, can you give, some indication of how much that your guys' kind of reach in this country has expanded since MIECHV came into place? I'm sure you don't have like a hard number, but just generally, how many
Yeah.
more people are you able to serve now that there's this federal, funding pot every year?
Yeah, that's a great question. I mean, yeah, Nurse Family Partnership has been around for 40 years, really began scaling up a couple of decades ago, worked, with the federal government, throughout the Bush years, trying to begin some of the first federal investments in home visiting. The Affordable Care Act was essentially the vehicle for putting MIECHV on to get that done. So kind of separate from the actual healthcare, but it did then have, some political ramifications there. But that MIECHV is really what has allowed Nurse Family Partnership to scale up. I mean, we are in 40 states across the country. Of the $400 million that goes out to the states with MIECHV funding, I think we receive around $80 million for Nurse Family Partnership programs. That allows us to serve a lot more families than we would be certainly otherwise. And it's also really allowed states to build out their systems and for, opportunities to look at broader funding than just MIECHV. But I really think of MIECHV as kind of being the backbone of home visiting programs in states across the country.
I'm not sure like this would be true across the board for your guys' programs, but I remember writing last time this came up, which was 5 years ago, that we had a cliff like this, and we'll talk a little bit about that in a second, but writing about the Oklahoma program for NFP, and I believe the number was that, 27% or 25% of that program was kind of funded through MIECHV. So, and I kind of remember other programs saying about that. So I've always had that in my head as like, it could be up to like a quarter in some states of the home visiting that happens is funded through this program.
Yeah,
through
absolutely.
MIECHV. So to that end, we're in 2022, rewind to 2017 or even further back. Affordable Care Act passes in 2010. MIECHV is a part of that. I think it's somewhere around like 2015, it got like a little 2-year extender to survive. And they just kind of punted on doing what's generally a real authorization is 5 years. So then in 2017, we get to, the same kind of situation where, they need to get something done to keep MIECHV going. As we reported at the time, started with a real belief that there'd be bipartisan support to double it to like $800 million. The Senate ended up with a flat reauthorization to just keep it as usual, $400 million a year. The House Republicans had a different take on it at the time. They wanted a version that could theoretically double MIECHV, but by kind of incentivizing, I don't want to say coercing, that's not the word, but steering states to match the money. So in theory, states would eventually have to get to where they were matching in full that $400 million or their piece of it. And so then in theory, if every state matched fully, you get to $800 million. So I say all that as preamble to ask, what is, as we head into this cliff again, what is the state of play here? Like, are MIECHV advocates trying to advance new ideas and how the funding would work or more money? Are Congress members looking to tweak this at all? Or is the goal this time really, let's just get a fresh round of what we have?
We are working very hard on reauthorization right now, and we are really pushing for additional funding for MIECHV because it has essentially been flat funded since it was created. There was that initial ramp up the first couple of years of the program, but since FY13, it's been at that $400 million level, and it's really causing impacts to programs. Workforce issues, not being able to serve as many families as we could. So what we're asking for is to increase the funding by $200 million for each year of a 5-year reauthorization. So building up each year on top. So taking it from $600 million in FY23 up to $800 million in FY24, keep ramping it up to $1.4 billion in FY27, which would be the 5th year of the reauthorization. There is bipartisan support for increasing funding for the program. I think that both across House, Senate, Republicans, Democrats, I think they really see the value of the program, and they understand that, $400 million 10 years ago is not the same as $400 million today. What we haven't seen yet is a commitment on what that actual funding increase is going to look like.
But is there even a, what they sometimes describe as like a discussion draft? I haven't seen anything introduced.
Yeah, there has been no discussion draft. There was a hearing in the Ways and Means Committee back in March. It was a really strong, positive hearing for MIECHV, but, we had heard the committee might have a bill out this summer. That didn't happen. And then certainly one of the really tragic circumstances of this last month was when Congresswoman Jackie Walorski was killed along with 2 of her staff in that car accident. She was our lead Republican on this, and she had been working with Congressman Danny Davis. They're the chair and ranking member of the Worker and Family Support Subcommittee. So, they had a long history of working on this. Congresswoman Walorski was a huge champion of the program. So we were expecting to see something soon out of the Ways and Means Committee. And, understandably, that some of that came to a pause.
Last time this thing actually expired, and then there were kind of several months where no money was flowing on MIECHV. And there wasn't also at that point, not really certainty it was coming back.
Yeah.
So it got to the point, I think in more like November, December, we're reporting on, decisions about laying off visitors, lowering the scope of people who are served by these programs. Our local, I'm sure you don't want to be in a position to speak to all different home visiting brands, but, as far as you guys are concerned, are you already seeing your local sites making those kinds of contingency plans? Are people at that point right now?
It's interesting because, I think last time was a little bit different. We were coming off of kind of a short-term extension. We never had a 5-year extension. So it was unclear what the future of the program would be. I think that uncertainty is still very real, especially for people who are here, who were working in these programs back in 2017. But there's kind of some technicalities here. The way the funding actually flows from HRSA, there's a lag there. So the FY22 money hasn't even gone out the door yet to states. Right. States will get that later this month. They will have that time to spend that down. So technically there is some cushion, but there is, the lack of actual authorization. And so the way different states might interpret that or administer that can look a little different. And the other thing to remember is we are committing to serving families for multiple years. So, if we're talking about a mom who's pregnant today, 24 weeks, say, we're talking about serving her for, 2.5 or more years. And so if states don't feel like they have that certainty down the road, sometimes you might start to see programs stop enrolling new families or maybe not backfilling those open positions. So we're both in this, I think, place where we're trying to make sure that Congress feels a sense of urgency to take care of this program and get this done, but also not to have, our workforce feel like they're in jeopardy, because we still feel like we've got time to get this done. There's a lot of support to get this done by the end of the year. We're all working really hard to make that happen. And so there's a little bit of a balance right now.
Are you a professional in the field of child welfare, juvenile justice, or other family and youth services? Subscribe today to Youth Services Insider, the imprint's exclusive section on all the insider news you need to stay in the know. Funding opportunities, major federal and state policy shifts, interviews with key leaders in the field. It's all available only for our Youth Services Insider subscribers. Sign up for a monthly or yearly subscription today by visiting imprintnews.org/subscribe. Our podcast listeners get 10% off their subscription by entering the promo code podcast10. That's imprintnews.org/subscribe and get 10% off your subscription by entering the promo code podcast10 today.
we were talking about like, has a bill been introduced or marked up or anything like that? I think probably a lot of listeners to this podcast are aware that how a bill becomes a law that we watch when we're kids is not always how these things
Yes.
go. I think the last time, if I'm remembering correctly, MIECHV ended up getting reauthorized in the same bill as the passage of the Family First Prevention
Yes.
Services Act, which I want to ask you a couple of questions about too. But those were, I don't even think that was an actual year-long spending bill. I think that was just a bill to keep the government open while they figured it out. So why I bring this up is I'm curious, first, do you think that, that's a likely path for this, that you could attach MIECHV authorization, even if there's not this general process of introducing a formal bill and marking it up and all those things? Do you see a path to attaching this? Do you feel like that's likely to
Yeah,
happen?
I think kind of all year we've been under this sense that there's going to be a big year-end package of all of the must-do stuff before Congress adjourns. And we've heard from committee and leadership offices that that's going to be the vehicle that we're most likely to move on. So that's going to be in December, though. That's not going to be before the September 30th deadline. What we are hearing now, though, is I think there's a real appetite to do a 3-month extension of the program as part of a CR. So we've never ridden with, an appropriations bill like that before, but I think policymakers really have heard the message about not having a lapse of the program. And, we have that history to look back on and what happened before. And so Congress is likely to do a CR to sometime in December. I think that date is unclear, but whatever that date is, that would likely be where we would, have that same date, and then just giving the committees a little more time to negotiate the actual, hopefully 5-year reauthorization with increased funding.
Do you feel like you guys have assurance from legislators, at least, that you will be categorized as must do in
Yes.
December?
Yes.
Okay. So that's got to feel pretty good. I mean, a 3-month, that was not present last time. So that's a form of continuity that.
Right. And I mean, of course, with all the caveats that there's no guarantees on anything. And, I think we'll see how the election plays out and what the appetite for a year-end package looks like in general. But, I mean, there's different scenarios, right? That could be a shorter extension than 5 years. And that's what we're really trying to avoid, a 1-year flat extension that just kind of kicks the can down the road. But we're also trying to avoid, funding lapsing as well. But
Gotcha.
We still have our eye on the prize that we can get a 5-year reauthorization with increased funding.
I wanted to ask you about the Family First Prevention Services Act, which I think is different than MIECHV, but also I think pretty relevant here because, the last time around, we didn't have another pretty major federal program that funded home visiting, and now we do. So I don't know how much that really impacts anything, but I will link to more info that we have on Family First, so I don't have to go into a long spiel. But basically, the front end of it allows Title 4E, the child welfare entitlement funds, to be spent on preventing foster care, services to prevent foster care. And quite a few of the programs that have been approved so far are home visiting programs, including the Nurse Family Partnership. So most states have been approved thus far for prevention services. They only recently got it. So as a funding mechanism, it's still pretty new. But, has NFP already seen an uptick in usage since the law took effect? I'm curious, how many states are using Family First funds to contract with you all to do home visiting now?
We're working on it. I think, as the implementation of that has been kind of slow and cumbersome in some places. And so we are in a number of state plans. Nurse Family Partnership is a well-supported program in the clearinghouse. Child First is a supported program in the clearinghouse. Certainly that is something we are working to do. But, I think the way we think about it is that we want to diversify, funding for our services. We want to not just rely on MIECHV, but even with MIECHV and Family First Prevention Services Act, there's still not enough dollars for us to really serve the need out there and to serve all the families that are out there. So I don't think it's kind of a one or the other. I think both of those things can work together to strengthen programs and, in some ways targeting different populations. And so I haven't heard that question a lot from policymakers, though, in terms of, do we need more MIECHV because there's, FFPSA? I think when we're talking about MIECHV serving 3 to 5% of eligible families, I think the answer is we need a lot more of MIECHV still.
Sure. Yeah. And to, you mentioned different populations, right? One thing I wanted to ask you about with this is MIECHV, and this is a pretty there's a pretty significant difference, I would think, between the two programs, which you guys and other home visitors will play in both kind of pods, right? MIECHV, you to be on that registry or that clearinghouse, and I think it's 19 or 20 now that are, you really have to be voluntary in nature, right? The model cannot be one where the parent, the client is compelled to participate by somebody. In
Right.
Family First, the way the law is written, I think there's some gray area here, but it's built around this candidates for foster care concept that suggests, the foster care would be on the table for a child, but for the services rendered under this 4E prevention services that you guys and other home visitors, are part of. So, I guess the question to me is, do you guys view that as voluntary as a scenario, or have you adapted a different version of your model to meet that kind of different reality under Family First?
I mean, our model is our model. And so, I think one of the principles of our model is really it's a client-centered approach. I think there are some circumstances where you have a different arrangement, maybe with, CPS that changes maybe the way how it's being felt as voluntary, I think, by the participants. But, in general, we see our programs as being voluntary, and that if families aren't feeling value out of them, they're not going to come. And our nurses work really hard to keep families enrolled. Retention is really important to us so that we can serve those families and get the outcomes that we're working for.
So I guess that's like a more kind of philosophical difference, I guess, in terms of business, right? Just the money coming out the door from the feds. I think it'll be interesting, probably not a really good answer yet to this, of just like how NFP and all the other home visiting models sort of end up seeing these two different opportunities to receive federal funding, and whether there's conversations with states around like, okay, we would prefer that you fund us out of MIECHV or 4E. Like I just seems like that's coming at some point when people.
Yeah. And there's a lot that we also, I think, want to get more from the feds out in terms of guidance grading funding, between Medicaid and MIECHV, between FFPSA. I mean, that is something that we are working on and talking about and looking for better guidance on.
Oh yeah, that's, I hadn't even thought about that, but do you guys have clarity on whether, because the 4E prevention services, they make it clear in the guidance after the law got passed that, especially as it applies to Medicaid, the 4E has to be the payer of last resort is what they call it. So if Medicaid can pay for something, you can't use 4E, this new Family First money, to do it. But is that true of MIECHV too? Like if MIECHV is paying for something?
I would say we still don't have real clarity there. We pushed for some better guidance. There's kind of a memo that came out in 2016 that said a few things. That's something that we still are seeking.
All right, Jenny, last question for you. We just went through, I shouldn't say that, we're still in the COVID-19 pandemic. We certainly went through a period where there was a lot of social isolation, a lot of shutdowns of services that, like your guys' model and like home visiting, really rely on interpersonal contact. And so a lot of the home visiting programs, I'm assuming would be true of Nurse Family Partnership too, went remote, went and tried to, as opposed to not doing anything, try to do things virtually. I'm curious at this point, do you feel like most sites around the country are back to something more resembling business as usual? And do you see, an ongoing role for a virtual component as far as, NFP is concerned?
That's a great question. Yes. I mean, we certainly did pivot. And I think we're all really proud of the work our nurses and our network partners did in doing that work and continuing to serve families throughout the pandemic when they really needed that support more than ever. And, finding ways to get technology into their hands and diapers into their hands when those were in short supply. And we learned a lot from it. We had already studied what telehealth or virtual home visiting would look like prior to the pandemic, but we really got to put that into practice throughout the pandemic. Most of our programs, I think, are back to doing visits in person. Some of that depends on the locality or the implementing agency. One of the other things that we are seeking on this reauthorization is continued flexibility around virtual delivery as a service, service delivery. And so we think that programs know what they're doing and that virtual component or that flexibility is an important tool for family retention. It's an important tool for worker retention. We don't think that virtual home visiting is how the program should be entirely delivered. We know there's certain things that are best done in person for nurse family partnership, those intimate partner violence screenings, those, looking at safe sleep environments. Those are things that are really best done in person. And we know that, fostering that really strong, trusting relationship between the nurse and the mom, we certainly did that remotely, but we know that we all know fostering those types of relationships, is often better done in person. But, we think that models can still implement with fidelity with some virtual component to it. And we want to, so that's something that we're asking for in the reauthorization, is to put that into the statute. That flexibility is okay. I think that's something Congress is still trying to think too about. How do they put that language in there the right way to still put some guardrails there, to make sure that we're still achieving the outcomes and, doing all the things that I think when they invest dollars in MIECHV, they're hoping to get from it. But we do want to see some level of that moving forward. And again, a lot of that's about meeting the family where they're at and what their particular needs are. And also as we think about rural areas and, some harder to reach places, that can help get to some of those harder to reach families.
Jenny Harper, Director of Federal Government Affairs at the Nurse Family Partnership. Thanks for joining us on the Imprint Weekly Podcast.
Thanks so much for having me.
Thanks to Jenny Harper of Nurse Family Partnership for joining us today, and thanks to the Kemp Foundation and iFoster for sponsoring this episode. The Imprint Weekly Podcast is a production of Fostering Media Connections, a California-based nonprofit that publishes the Imprint, Fostering Families Today, and operates the Youth Voice program. This podcast is produced and mixed by Christine Anjoko, with music by Luke Giroux and Cyrus Elia. If you enjoyed this episode, we would love it if you'd consider subscribing or giving us a 5-star rating on Apple, Spotify, or wherever you download your podcasts. And we'd really appreciate if you would support our work here on the podcast and in print. Small donations from our listeners and readers go a long way towards helping us grow and cover more great stories in child welfare and youth justice. To support us, it is super easy. Just visit imprintnews.org/donate. You can follow The Imprint on Twitter and Facebook by searching the handle @TheImprintNews, and visit us on the web at imprintnews.org or email us at tips@imprintnews.org. I'm John Kelly, and we'll see you next week.